I'm Erica Thompson. I'm an assistant professor at the University of North Texas Health Science Center in our School of Public Health, and I'm joined by Anna Galvin, who is soon to be Dr. Galvin here in a few months, who's a PhD candidate here in the School of Public Health, and we will be sharing some of the work that we've done locally to look at reproductive health needs for our local community. And we're thrilled to do this in partnership with the Center for Transforming Lives. And Carol Klosik, who's the CEO for CTL, is going to share a few words.
Thank you so much, Erica. I'm really excited about this conversation and the opportunity to talk about this issue. Center for Transforming Lives, for those of you who are not already familiar with us, is an organization here in Tarrant County focused on working with women and their children in a two-generational trauma-informed way that helps families move from poverty to prosperity. We do that through our housing services, our early childhood education efforts, clinical counseling, and economic mobility work. And we have, while we work with people who are across the spectrum of those living in poverty and low income, one of our areas of focus are families who are experiencing homelessness. We did a study several years ago and with Dr. Thompson as a partner in this, and looked at those families experiencing homelessness under the Department of Education definition, as well as the Department of Housing and Urban Development definition. And what we found is that using the Department of Education definition, about 15,000 children are experiencing homelessness, and but a much smaller, only in the few hundreds, are under the experiencing the kind of homelessness that's really addressed in the homeless services system. So we started asking ourselves about why that is, and really saw that families, once they are experiencing homelessness, do have a difficult time accessing services within the homeless services system, and one of the barriers is family size. So as we looked at family size and saw that family size for families that are experiencing homelessness is increasing, one of the things that really that points to is when we do see families that have larger numbers of children or children that are very close in age, it points to a possible lack of access to contraception. So we were really excited about the opportunity to study this more in depth and work with our partners at the School of Public Health here to understand what's happening in the system and understand the realities for women.
Thank you so much, Carol, and for highlighting that prior work. And I really do see it as this kind of trajectory of partnership together to really figure out how best we can serve these families and women in our community. So today, it won't just be us talking. I hope that we have a conversation really around contraception and postpartum health care needs for women experiencing homelessness. Anna and I will be sharing some of the research studies that we've done here. We don't want it just to sit on a shelf. We want to be sure it's going back into the community and you're hearing what we're hearing from the community. And then we'll have some time to talk about what does this mean for Tarrant County and for Texas, with some small breakout rooms and discussion. So that's what we have in store for you today. And I, of course, like to acknowledge the Center for Transforming Lives for partnering with us on this session. The work was also funded by the National Institute of Minority Health and Health Disparities through the Texas Center for Health Disparities. And we have a number of collaborators here at the School of Public Health, as well as community partners who really enabled this work to be possible. So we could not do this without you all. So for folks who may be more on the housing side of things, you may be wondering, well, why focus on reproductive health? And Carol, thank you for that nice introduction and segue. And from a public health perspective, we see reproductive health as being really key to overall well-being. So women having the ability to decide when and if they ever get pregnant is critical to, how they progress in their lives and for their family as well. some of the indicators that we look at in public health are related to unintended pregnancy, and that's when a pregnancy is either unwanted or wanted at a later time. And about 50% of all pregnancies in the US are unintended. And then also we look at birth spacing. So making sure there's enough time between each pregnancy that gives mom enough time to recuperate and brings forward healthier pregnancies as well. So critical to some of these outcomes is contraception. So we might think of it more in layman's terms, birth control as well. We might typically think of things like condoms, but there's a whole range of different types of contraception, which make it a little bit more complicated for anyone. We have methods that are forever methods, like tubal ligation for women, but then we also have these methods that work really, really effectively. We call them long-acting reversible contraception, or LARC, and they're things like an implant that would go into the arm, as well as IUDs, and they're really effective at preventing pregnancy, and you can place them and forget them for several years, which adds to their effectiveness as well. Then we have other methods that are in the moderately effective range, like the pill or the Depo-Provera shot or the ring, that require some user interaction. So that's where their effectiveness gets a little lower, because it requires someone to remember to take a pill every day. And then the methods that are lower on the effectiveness range are things like the fertility awareness method or withdrawal, as well as condoms. But we know that condoms are the only method that could prevent sexually transmitted infections. So people really have a wide range of options in terms of determining what method is best for them, as well as what access they have to these different types of methods. And we are specifically focused on women experiencing homelessness because they are a more vulnerable population. When we think about sexual health risk, these women are at increased risk of survival sex, sexual assault, reproductive coercion, and intimate partner violence. And we also see that unintended pregnancies, so those unwanted or mistimed pregnancies, happen at a higher rate for women who are of lower socioeconomic status. And we also know that women experiencing homelessness may face more difficulty accessing healthcare services, and previous studies have found that they have lacked getting any comprehensive contraceptive counseling from their providers. So really going over all those different type of methods and figuring out which method is best for them. And we also want to focus on reproductive health for women experiencing homelessness because, as Carol mentioned, that two-generation component, it has consequences across the life course. So it may perpetuate the cycle of poverty if more children than you were wanting to have and could afford. Of course, we want people to have as many children as they want to have. We're not saying otherwise. It could also, unintended pregnancy can also increase the risk of lower birth weight, preterm birth, or longer hospital stays, and also have consequences for children in terms of adverse childhood experiences and other challenges. And so where Anna and I have been focusing is primarily in Tarrant County. These numbers for women experiencing homelessness are national. In 2020, we went to the pre-pandemic numbers. Since 2021 data, I think are still a little wonky because counts were a little different during the pandemic, but about 500,000 people were experiencing homelessness according to the point in time count in 2020. And that's that stricter definition of homelessness that Carol was mentioning. But about a quarter of these individuals are women, and many of them in families as well. So not your typical person experiencing homelessness that I think most people think of in their minds. These are women with children who are unstably housed. And in Tarrant County, there's about 2,000 people, more than 2,000 people experiencing homelessness. So we were focusing primarily on women in our local community. So I'm going to start by talking through some of the work we've done related to barriers to contraceptive access in our local community. We conducted this study pre-pandemic, starting in 2019, had a major pause because, COVID started and everything shut down, and then we're able to finish up data collection in October of 2020. And we talked with 19 women who are experiencing homelessness, who were of reproductive age and capable of getting pregnant. They came from a range of different locations like rapid rehousing, emergency shelters, transitional housing programs, unsheltered. And then we talked with 6 healthcare providers and 6 housing organization workers in the community with the goal of really getting this full picture of what are those barriers and facilitators to contraceptive access for women experiencing homelessness. And our hope is that by understanding these barriers and facilitators and conversations like we're having today, we could perhaps look for what do we do next? How do we develop programs and interventions to reduce the risk for unintended pregnancy? So I'll be sharing some of our results across the socio-ecological model, which is the model we use in public health that recognizes, our health behavior and health doesn't happen in a silo. It's really an interaction between the individual and the system they're in. So the individual's knowledge and attitudes and beliefs are important, but also how they interact with their healthcare provider or family at the interpersonal level. Factors at the organization or community level, such as having access to contraception and office hours for clinics. And then at the societal level, things like policy and norms can also be influential. So we're going to walk through these study findings from those interviews that we did back in 2019, 2020. We'll start first by talking at the individual level. So again, talking with those 19 women, 6 healthcare providers, and 6 social service providers. First, from the women's experience, they shared, similar to any woman, they have personal preferences for different contraceptive methods. And this was likely due to, they reflected on, I've used this method before, I didn't like it, or I heard so-and-so had these side effects, so I would prefer this method. And there were many misconceptions about different types of birth control, a lot of this anecdotally from conversations with others. So very similar to what we see in the general population in terms of contraception knowledge and awareness of different methods and preferences. When we talked to healthcare providers, the healthcare providers shared they had a strong desire to develop better ways to reach this population and focus on reproductive health, mentioning that it wasn't always a priority. And the social service providers also mentioned some interest in this area as well, but that their personal viewpoints could potentially impact the delivery of care. It's not necessarily a topic that everyone's comfortable with. But overall, women shared that they want more information about contraception and reproductive health generally. And all the groups we talked to were unsure where to go or send women to access these services. So as one woman shared, talking about accessibility, she said they're accessible but not really visible. So talking about birth control. I'm thinking more or less that these things need to be more visible and then maybe pamphlets next to it or in the vicinity. Another woman shared it's not as easy as it should be to access contraception because a lot of the places you go are churches and churches aren't going to hand out condoms. So talking about just where to go in terms of accessing contraception being more challenging. At the interpersonal level, so our relationships with other people. The women talked about their relationships with their family and their sexual partners being influential to their decision-making about which contraception method was best for them. Women also reported wanting to talk to their providers about contraception, specifically their healthcare providers. But on the flip side, the healthcare providers were almost waiting for the women to bring it up and said they assumed that the women weren't interested because they weren't asking about the contraceptive methods and instead tend to focus on competing health priorities compared to reproductive health. Women also reported being open to talking about reproductive health with their case managers or social service providers, even if it's just assessing, is this a need that I have and where to go to get particular services. So a social service care provider shared with us, we try to establish a healthy relationship with clients and build trust. So I think conversations about contraception would be received positively. So their viewpoint, and as I shared, women were open to this type of conversation. And for healthcare providers thinking about conflicting priorities, they shared contraception counseling is not different. It's more that there are other equally critical things that come up. You know, where are you going to sleep tonight? Where are you going to have your meal? What's your relationship like with your partner? Substance abuse, a lot of other things, mental health. So that's where it's kind of, unfortunately, from a provider standpoint, we forget, which is not great. Now, moving up that socioecological levels and thinking about the community or organizations, we asked everyone to kind of reflect about the systems that they may interact with and the different organizations within our community. In terms of culture, providers shared that there is this need to emphasize reproductive health, but not all organizations may be able to do that based off of leadership or culture and values that those organizations may have. In terms of operating procedures, there was the question raised by the healthcare providers on how best should we be measuring pregnancy intentions. So you have women that you're interacting with, but maybe if we better measured a woman's pregnancy intention, then the concept of reproductive health and contraception could come up more naturally, as well as there was really a lack of any type of reproductive health questions on intake forms across the different services. Healthcare providers also discussed the lack of same-day LARC insertion. So again, going back to those highly effective methods like IUDs or implants, they're more challenging because if you don't have it on the same day, a woman's going to have to come back to clinic multiple times to not only talk about getting the method, but then getting it inserted. So a population that has trouble, with transportation, this becomes an added barrier. And then finally, connectivity came up across organizations. Some social service providers have relationships with healthcare provider organizations for basic care, but not necessarily for reproductive care. And both of the provider groups we talked to really talked about a lack of connectivity between the two professions, or connectivity that could be strengthened. One social service provider shared, I think there are a lot of organizations that are faith-based. There's a lot of judgment. What we hear is they really prohibit women from accessing the services they need to care for themselves physically and to prevent pregnancy. So thinking about the type of organizations can also, what organizations women are interacting with can impact their access to reproductive health, and how maybe we could move some of that out of the social services. And a provider also shared, I think we need a training for our case managers. We would need a data capture, a list of referral sources and relationships to provider to better enable those services for women for reproductive health. And then lastly, at the societal level, these are things that I think are familiar to many of us. Transportation is one of the bigger barriers for women in terms of getting access to reproductive health care, the timing of the clinic. And even if a woman can get vouchers for services for transportation to get to those clinics, childcare then becomes an additional barrier. Reproductive health is also has additional challenges in Texas in terms of how our Medicaid is set up, and funding for that comes through Healthy Texas Women. So health insurance coverage becomes an added barrier for women. This was reported from all the groups that we talked to. And there may be added co-pays or other financial requirements for certain types of methods that make it further challenging. One woman reflected on the cost issues. She said, it's like 1 minute you're paying for it, and then the next minute you can't pay for it and you're off of it. And it's like, oh my, because of the insurance, I might be pregnant next year. A healthcare provider also shared, if women do or do not have insurance coverage, and then because to get on those programs, it takes a lot of time, and that ties into transportation. A lot of things we see in our demographic is struggling even to make it to the clinic because you may be working, you may not have childcare. All of those kind of social issues feed into the inability to make it to a scheduled visit. And we know that most of our contraceptive methods that we talked about earlier are all tied to having some sort of in-person visit. So we were really fortunate to share some of these barriers that came up across the socio-ecological model with stakeholders in our local community and advisory board. And we went through and prioritized what are areas that we could address and what are potential solutions. And I'll briefly share some of these potential next steps in terms of future work. One is providing education to providers to increase confidence in contraceptive counseling, or even bringing up reproductive health and connecting to services. And some of that could be facilitated by adding sexual health questions on different intake forms. Another potential option would be a patient or peer navigator who could be helping women navigate the healthcare system and initiate conversations while establishing connections to those different provider groups and reproductive health. And then some of the bigger system changes that could take more time could be things like mobile healthcare, focusing more so on reproductive health and meeting women where they're at in terms of shelter, other unsheltered locations. And I know we have a phenomenal mobile healthcare team here in Tarrant County. And then also reducing the barriers related to same-day LARC insertion by addressing funding streams, availability of those methods in clinics, and reducing the need for multiple appointments. So I know that was a lot to digest, and we'll have some more time to talk through that in a moment, but I'm going to turn it over to Anna Galvin to share some of her work that she's been doing.
Great, thank you so much. Hi, everyone. We've learned a lot now about these unique contraceptive needs and preferences for women experiencing homelessness. So now I'll transition to these broader reproductive needs for recently postpartum women experiencing homelessness, with anywhere from newborns to young children under the age of 4. And this time period we'll also refer to as the interconception period. So many of you may be familiar with this perinatal timeline of preconception, of prenatal care, and then postpartum care. So interconception care focuses primarily on care between pregnancies. Like Dr. Thompson had mentioned, the goal of interconception care is to reduce these unplanned or mistimed pregnancies, or potentially space out pregnancies to reduce any risks related to short pregnancy intervals like prematurity, congenital anomalies, things of that nature. So based on our recent findings, we did have some additional questions on how to best capture this information during that interconception time period. So first of all, we wanted to know, were women experiencing homelessness engaging in these different types of interconception care focused on their family planning and contraceptive use? And did this really differ from women who were stably housed? And then the next question we had was, what were those unique barriers and facilitators that affected this behavioral uptake for this population who were recently pregnant and homeless? So to answer these, we looked at both national data and then also conducted local interviews as well. So for the national data, some of you might be familiar with this, but we utilize the U.S. Pregnancy Risk Assessment Monitoring System, or PRAMS for short. They interview a random selection of women who are 2 to 6 months postpartum and ask them a lot of different perinatal questions. The map shows the different states that participate, and the ones with the little housing icons, about 33 states, including Texas, also ask a question regarding whether they had experienced homelessness in the last 12 months. So of this sample, we utilized the most recent phase, so from 2016 to 2019, and we were able to have a sample of 100,706 women who reported yes or no to that housing question, as well as having a live birth and a child alive at the time of the interview. And of that, 2,953 women, or 2.4% of the women, did report experiencing homelessness in the last 12 months. And for our primary reproductive interconception care outcomes of interest, we looked at whether they had attended their maternal postpartum visit, and then if so, if they had conversations about birth spacing, contraception family planning, if they had received a prescription for those short-acting birth control methods like the pill, and if they had a long-acting reversible contraceptive inserted at the time. So of those 5 outcomes, 3 were found to have statistically different proportions based on whether they did or did not experience homelessness. So the first one, as you can see in the first left column, for attending a maternal postpartum visit, there is a higher proportion of women who did attend that did not experience homelessness when you compare it to women who did. And then alternatively, for these other 2 outcomes regarding pregnancy interval conversations and postpartum LARCs, women who did experience homelessness had a higher proportion of women who did have those conversations and did have LARCs inserted compared to women who did not. And so for this, we did establish that there are some relationships, but as you know, homelessness is not the main cause necessarily of why these behaviors happen. We know that there's a lot of different factors that come into play, like if the woman had insurance or if she had any prenatal care at all. So we wanted to also see if homelessness was still a significant factor when keeping these in mind. And short answer was yes. So when we adjusted for these other factors, as shown here in the bottom, like maternal age, race, ethnicity, education level, and a lot of other prenatal and preconception conversations, we did find that women experiencing perinatal housing instability did have a 55% lower odds of going to their maternal postpartum visit, as well as a 30% higher odds of having these conversations about pregnancy intervals. So we were able to establish that this was present in like a national sample, but now we wanted to look further within a local sample. So based on the findings from the large national sample and utilizing a health behavior framework known as the Information, Motivation, and Behavioral Skills Model, we had developed a semi-structured interview guide, which we were able to review with some community members as well, just to make sure it was readable and appropriate for the population. And we were very fortunate through our recruitment methods that were somewhat difficult initially because of the recent surge in Omicron, but we were able to interview 12 women who were recently pregnant and experienced homelessness. And just as a brief overview, this is the model that we had utilized, noting that a woman's information capacity, their motivation to engage in behaviors, their behavioral skills, like knowing how to engage in the behaviors, are all interrelated and influence health behavior, and also exist within a macro system level scenario to where, like what Dr. Thompson also mentioned, how behavior is not necessarily just individual based, but also affected by several other social determinants of health. So we'll start with the information themes that we found from our interviews. So regarding maternal postpartum visits, they had received various education, especially reproductive health education, and at the time of these visits, which is really important since they already had like a mindset of engaging in these types of reproductive and sexual health conversations since they just had a child. But some women did report that they did leave the visit wanting to know more. And they really valued the sources of information from their OB-GYN or their postpartum healthcare provider. But they also acknowledged they did have other resources such as social media, some TV commercials, and other different types of information from their family and friends. And with birth spacing and family planning, some providers did mention or did talk about, what were their pregnancy desires or future pregnancy planning, but they did have some discrepancies based on how long they were told how long to wait between pregnancies. So some women were saying like 6 months, some women were told like 1 to 2 years, some women were like given vague answers as far as like when you feel like you've recuperated enough. So for reference, the American College of Obstetricians and Gynecologists report saying to definitely have a conversation about the risks and benefits of having a child within an 18-month interpregnancy interval, but then also emphasizing to try and avoid having an interpregnancy interval of 6 months or less due to strong evidence of potential adverse outcomes for the mother and the baby. And for contraception and pregnancy prevention, contraception misconceptions were very prevalent, like we know from the other study, but and they're also very knowledgeable about the different types of side effects as well. And some women, based on their preferences, had reported that their provider did try having conversations with them about birth control and family planning, but they just were not hearing it because they already made up their mind that they did not want to have any birth control at all. So here are two quotes. One woman noted that her children were 15 months apart and her most recent daughter was unplanned, but really felt that birth spacing was really important to know and wish she had known more about it during her first pregnancy. She said she would have been more strategic about not getting pregnant within that time frame. Another woman reported having knowing about IUDs and was worried about essentially getting it stuck. And so she noted sure, I know that there's other signs and symptoms related to IUDs like weight and periods, but the one thing that really put me off was that image of that IUD getting stuck. So for motivational themes, for all of these different outcomes, women reported, they acknowledged that it was very important to engage in these behaviors. However, their perceived health for maternal postpartum visits, for example, their perceived health at that time made it feel like less of a priority to go. So if they had a pretty easy recovery and were feeling well, they were less motivated to go check in with their maternal postpartum provider. And some women who didn't want to go had no social support system to help them attend the visits or motivate them to go. So they didn't. And with birth spacing and family planning, women were happy with the number of children they currently had, but sometimes other people like their partner or family were really encouraging them to have more or have more sooner. And then some wanted their children to just be closer in age or to just kind of get pregnancy and delivery over with. So they wanted to just have that done sooner. And with contraception and pregnancy prevention, there is also this perception of pregnancy risk and emotional ambivalence to pregnancy. If they were to get pregnant, a lot of women said, well, I guess that's what happens. And they were able to list several reasons for not wanting to engage in postpartum contraception, such as their partners not liking contraception, them not liking contraception in general, abstinence, their preference for that over contraception, and other factors. Here, this woman reports, it's very important. She had a child before, and she knows that this was in regards to maternal postpartum visits. So she instead just decided to stay home because she didn't like how invasive her recent interaction with the healthcare system was, and she was in pain. And so she just stayed home. She knows it's important for the first child, but this was a separate child, and she was also dealing with housing issues. She knows she wants to go, and she knows she still needs to, but she just could not at the time. For behavioral skill themes, we have, some women reporting what made it easier and what made it difficult to attend maternal postpartum visits, like opening up to people in general, to their clinicians, having difficult C-section recovery times or trauma from the delivery, and also just availability of appointments and the process of scheduling. For birth spacing and family planning, they wanted to have everything ready for the next baby in place, so that made it easier to space out the babies because they wanted to get their housing situation settled first, or they just did not want to have to go through being pregnant again based on their recent experiences. But on the other hand, there were also time pressures and biological clock and fertility concerns that made women have more difficulty with spacing out births. And for contraception and pregnancy prevention, previous experiences that they've had on contraception kind of influenced whether or not they were likely to continue that in the postpartum period. And a lot of women also did report preferring abstinence over contraception, and they either did that, or some women reported having immediate postpartum LARCs inserted or tubal ligations while they're still inpatient in the hospital. For this woman, she notes that she didn't want any more kids, and she wasn't sure though, so she still had some of that ambivalence. So this was a positive encounter with her healthcare provider about how she talked about the implant. So the provider was like, this implant lasts for 3 years. So if you want to have kids after 3 years, you can. If you don't want to have kids anymore, you can get another one in. But if you do decide that you don't want, or if you want kids sooner than that, you can always have it taken out. So it felt like she still had a choice, just like regular birth control. And then lastly, with these macro level themes, we had COVID being a really big consideration during this time. So for maternal postpartum visits, it changed like their visitation policies, their employment, their concern about the health for their child and their others, and then having this additional support with transportation and childcare, which is a very common theme that we've noticed as well. And there was also insurance status confusion, noting that sometimes it's difficult to navigate Medicare and insurance in general, but having this transition period between being postpartum and having your child and when coverage starts and stops was really confusing as well. For birth spacing and family planning, there were different maternal age factors, whether it be too young or too old to have children, availability of the current resources for housing by the time they do want another child. So if they have a housing by that point, they might consider it, but if not, they probably won't. And then there's challenges in raising multiple children in shelters, which we also found similar themes in the previous study regarding families experiencing homelessness, how sometimes having the children in the shelter was more of like a barrier to engaging in anything else because they were very concerned about trying to make sure that their children were safe. And then with contraception and pregnancy prevention, just access to contraception timing, renewal, removal, and things of that nature at the time of discharge versus at the 6-week appointment, noting that birth control is very expensive without insurance, and having storage and privacy concerns within the shelter. So then for this woman, she says her fiance was still making rides to work during her prenatal period, but then eventually couldn't find anyone to take him, so he had lost his job. And then one thing after another, their savings only carried them for so long, for having to stay then at like a motel, but then afterwards not having enough government assistance because they didn't like qualify for it at the time. And all of that essentially accumulated to like once the child was born, having to come to shelter, which was not ideal for them in that situation, and wishing they had assistance earlier on to have prevented that. So here are some of the next steps based on what we found for both the national data and the interviews. For the information portion, we found that there was a need for getting more education out to families while also addressing like these key misinformation and concerns about reproductive interconception care. So research may be looking into opportune times for initial and follow-up conversations were really important. Like, when do we have time to have these conversations, or is one time period better than another? Regarding motivation, there is a lot of ambivalence and these mismatched attitudes about reproductive interconception care. So if we can try and figure out how to elicit some positive change talk towards positive healthcare behaviors while still honoring their autonomy and their right to have children with the reproductive, or yes, to have autonomy and decision-making to improve that congruence with their reproductive health goals. Social support was also a key factor that they mentioned was important, knowing that sometimes women in these situations feel isolated. And a lot of women reported experiencing trauma related to partners, family, or sometimes interactions within healthcare systems. So acknowledging these barriers in a trauma-informed manner can really help improve outcomes as well. For behavioral skills, we just noted that there might be ways to integrate support for these visits across several systems and continue to discern how much women are capable of engaging in these behaviors based on actual ability or actual like motivations to want to change. And lastly, these macro level factors requiring current housing and healthcare policy, like from things like what was previously mentioned regarding how we define homelessness, how we encourage supportive economic policies and poverty alleviation, and even improving access and affordability of healthcare, while also acknowledging the intersecting roles of like race, socioeconomic status, gender, and sexual orientation, and all these other factors that come into reproductive decision making.